was given the topic, they said, we're looking at legal aspects of healthcare business. And I wondered about what to say. One of the first things that came to mind was some of the challenges that we've been dealing with in the e-health space. And we've talked about e-health quite a bit today. People calling me up and saying, so we want to run this virtual thing around emergency care, around sexual and reproductive healthcare. Can you advise us? Because we don't want to run foul of any regulations and so on. And I thought, wow, that would be interesting. But then, from time to time I go to different things. And even when I came here this morning, it wasn't different. People walked up to me and they said, what is health law? I mean, this is new. This is relatively new. I'm going to tell you a story about how I came into the space and why I think it is important. While I was in school, there was something we did around HIV/AIDS was quite big at the time. So it was something on HIV/AIDS prevention. And I was wondering, is there no way we can link law to some of these really interesting things that are happening on the ground with healthcare? At that time, there was a lot of discrimination and so on and so forth. And then I learned about this Canadian university that was offering a scholarship to come and read health law. And I thought to myself, what a fantastic opportunity. So I headed off to Canada and so on, and I did health law. Now you have to remember that at that time, we just had the NHIS Act passed. Nothing was really happening. We didn't have a legal framework for the health system. Maybe it was just all jumbled up, and then maybe you had the Medical and Dental Practitioners Act, and I remember trying to write my thesis and looking for this act all over the internet, and nothing was happening, and so on. Now, fast forward almost 20 years later, we have a lot happening, at least from a legislative perspective. Okay, and so I want to talk about a little bit of that. Now, somebody mentioned earlier, I think it was Lawal from Epidalat, about the National Health Act. So I'm going to kind of take off from there. So we had the NHIS Act, and then we had people agitating. Why can't the law intervene in the healthcare space to open up access, to help improve quality, and so on and so forth? And a lot of advocacy went into that over a period of over 10 years. And then in 2014, the National Health Act came into being. The National Health Act does a variety of things. It provides for, basically, first of all, it tells us what the health system is from a legal perspective. And it includes both public and private sector. So here we are, so we're legitimately in the room as private people working to develop the health system, right? And then it also provided for the Basic Healthcare Provision Fund under Section 11. And there's been a lot of talk about that, and I'm going to talk a little bit about that. But it's a sort of supplementary funding for the healthcare system, to put in some funding, particularly for primary healthcare, which we've talked about a little bit today as well. In addition, it provides for patients' rights. So it itemizes, the right that you have the right to consent. Things that some of us in this room might take for granted, but talk to a regular person, even a professor of economics like my dad, and you will realize that they're afraid to ask doctors questions. So this medication you're giving me, what is it really going to do? And all of that. So it has all those rights, right? The fact that there should be a complaint system in the healthcare facility, the fact that there should be a certificate of standards, which every health facility should have. And that certificate of standards would include things like even whether or not the healthcare worker behaves appropriately towards you and so on. We've now moved from the NHIS Act, and I don't want to talk too much about that because it's a very interesting issue. Let me use the word interesting. But because of some of the flaws and defects that have come out of that act, one of the things that the National Council of Health thought about was that it would be a good thing for states which had, hitherto been very wary about joining, the National Health Insurance Scheme, could set up There's what we call the state-supported health insurance schemes. I think we've mentioned that quite a little bit this morning. Farm Access supports one of such schemes in Kwara State and has done quite a bit there. Lagos State hopefully will launch theirs before the end of this year, and so on. All of these are based on a legal framework, and I'm happy to say that I participated in drafting that legal framework. Now, so much is happening, isn't there? So we have, the Delta State has their own state-supported health insurance based on a law. Anambra State has passed their law. The River State is about to do theirs. All of this will open up the space, inject some money, give work to the private sector, whether they're working as third-party administrators or whether they're working as HMOs, depending on the model that the state chooses. So that's all fantastic, isn't it? Beyond that, there are things that are happening outside of health-specific legislation. There are things like, the Equipment Leasing Act. So the Honorable Minister mentioned equipment leasing in passing. We also have the Collateral Registries Act. What does the Equipment Leasing Act do? It allows you to know what the roles and responsibilities of people who are in equipment leasing have, people who want to lease and people who are leasing, and so on and so on. It details it in key respects. It's an alternative form of financing. So of course, if you're a health facility, you want to obtain the best equipment possible, you don't actually have to lay out the cash, start looking for capital to buy that equipment. You can actually, lease that equipment over a period of time and pay over a period of time. And if you get an excellent lawyer like me, marks for modesty, we can help structure it, throw in things like maintenance and so on, and really good terms for buying out at the end of the day, and things like that. And you have the Credit Reporting Act, which are not health sector specific, but things that we can use in the health sector to develop, to open up the space for financing and so on and so forth. So the collateral registries allows you, instead of using real estate, you can use, movable estates, and this can be registered under the Collateral Registries Act, and, financial institutions will have that to rely upon when you go for loans and so on and so forth. So it would appear that since I left and went to Canada over 20 years ago, almost 20 years ago, or whatever, lots of things have happened, of course. So are we in Uhuru land yet? The answer is no. We still have a ways to go. I will start with some of the things that we can still do. For example, we're talking about business. We want to engage business in private-public partnerships. We're already doing that, but there's a lot more to be done in that respect. We have to build the political will for that, as well as the legal framework, at least at the national level, because I know that in Lagos State they have a public-private partnership law that gives investors the confidence that when I go into this deal, I'm going to come out with my money, and so on and so forth. When we talk about e-health, there's still a lot that is, fuzzy-wuzzy in terms of, knowing what the standards are, what the regulatory requirements are, and we might, and I know, the Federal Ministry of Health is working on something because I'm part of a technical working group working on that. But we also are going to need, the Medical and Dental Council as well as other professional regulatory bodies to step up and look at the areas in which they might want to regulate. Now, when we think about regulation, businesses get worried and all of that. But we do need standards. We do need to be sure of what we're doing. Of course, the law is also here to create an enabling environment. But let me also go to the other thing that many people think about once you say health law. Once you say you're a health lawyer, they say, oh my goodness, you do medical negligence. So medical negligence is one key thing. We've talked about medical tourism. One of the things that drives medical tourism, and we've heard the figures, and we imagine what those figures would do within this country for our healthcare space if we injected that funding here. One of the things that is driving medical negligence, as the minister rightly pointed out, is confidence. confidence. And confidence comes from believing that you're going to get quality care. That if I go into a facility, what they're telling me, they're giving me the right thing. So we're very happy to have people coming back. But we also need then to work on our regulatory structure. We want a viable Medical and Dental Council of Nigeria. At the moment, I don't believe that we have. The council is sitting, and that means the tribunal is not sitting. So the investigating panel has a long backlog of cases. And we should be in a system where people want the professionals self-regulate because they know what the standards are. Now, when you have a client who says, I've gone through this situation and I really want to sue, and people are beginning to sue because social media has made even sharing parts of the National Health Act so easy, so that people are beginning to realize that we have rights when it comes to healthcare. So I have clients who call me and they say, we will not settle. I do not want to settle. Don't ever talk to me about settling and so on. So we definitely need to build up quality, and we definitely need to build up regulation. When that happens and we come to litigation, one of the things that we have really found difficult has been, getting expert evidence. So doctors and nurses and other healthcare professionals believe that they're protecting themselves by saying, this is, they will tell you quietly within the room, oh my goodness, who did this? They could not have been to any medical school that we know about, but they're not willing to say so publicly. We need to begin to get to a point where we hold people to account. Accountability is important for quality. Granted, we have a brain drain problem. We don't want a situation where people feel witch-hunted into leaving the country, obviously. But we also want a situation where we keep people in from going out to India and other places where they go, and sometimes they too have stories to tell. If we haven't protected them here, obviously we can't protect them outside of here. Beyond that, somebody mentioned something about the advertising and what the Code of Medical Ethics, which is, by the way, subsidiary legislation, meaning that it actually has the force of law. What it says about advertising. I can go into a little bit more detail if you engage me one-on-one, but truthfully, as it stands today, if you look at that provision, facilities can actually advertise. Of course, people are afraid to do so, but if you look at it, it would say that healthcare practitioners cannot advertise. That doesn't mean that facilities cannot advertise. A healthcare practitioner cannot advertise, and there he is telling you, but we have somebody that we work with in India, and so on and so forth. That is a problem. Okay, finally, we need implementation. So we've passed all these beautiful laws that I've mentioned, and it seems that all is going well, but we know that from an implementation perspective, we still have ways to go. We don't have a certificate of standards in place, and the Basic Healthcare Provision Fund has not been put in any budget since 2015. What do we do about those things? Because I know that questions will come from Lawal and all that. The answer is that I don't know, but I do know that we are all stakeholders in this business. I won't say political will. How does political will come about? Political will comes by pushing and pushing and pushing. The National Health Act came about by a whole lot of advocacy by many partners, many of whom are in this room. So we have to push. Otherwise, there are dead words on paper. From time to time, people will call me to clarify a provision, and I send them my fee note and send money into my bank account, but that is not going to get us where we need to go. So we need to begin to align ourselves. Lots of people have talked about health activism and about advocacy. So the law, one of the good things about law is that it presents you with an advocacy tool, a ready advocacy tool that will outlast any administration unless they repeal the law properly. So lots of things are happening. I know that the National Nigerian Health Watch, for example, they've been running a campaign around Health for All Niger. And one of the things they're campaigning around is getting states to adopt health legislation, we can align ourselves with those kinds of initiatives. There are people who are trying to raise signatures for the Basic Healthcare Provision Fund to be implemented in the coming budget next year, and so on and so forth. So lots of interesting things are happening in the space. There are people who are, I didn't talk about the HIV Anti-Discrimination Act. There are people who are campaigning around that. We can align ourselves with those things, at least from a legal perspective, in order to move the healthcare space forward. These health laws that we talk about, that for us to open up equity, open up access, and improve quality. Thank you very much.